Welcome back on the Coalition 936 podcast. I am JP Heath. Our next guest is Dr. Sid Roberts. He is a radiation oncologist at CHI, St. Luke's Memorial Hospital in Lufkin. Dr. Roberts, thank you so much for being on. We really appreciate it.
Oh, you're welcome. Glad to be here.
So, you don't know this, but you've been a bit of an inspiration to me. I've hung an article that you did an op-ed for the Lufkin Daily News a few years ago that we're going to cite coming up in a little bit. But just thank you for what you do, and thank you for what CHI does. For people that are not in the Texas forest country that might be coming across this interview because, hey, it's out there in the ether, in cyberspace, just to explain at its most basic root what a radiation oncologist does and how that fits into CHI's health mission across, obviously across America, but here in our little neck of the woods here in a great area of East Texas.
Sure. Well, I guess the simplest way to start is to explain that when someone is diagnosed with cancer, they may get one of several types of treatment or a combination of treatments, as it turns out, including surgery or chemotherapy or radiation therapy. And those are broad categories, as a matter of fact. But each of those areas is a specialty in and of itself. So a medical oncologist does chemotherapy and a radiation oncologist does the radiation treatment for cancer. So part of what I do is to consult on patients who have a new diagnosis of cancer and determine if radiation therapy is going to be a portion of their treatment. And if so, how do we coordinate that with their surgery and their chemotherapy, for example? So we all work together to make those decisions.
Mm-hmm. And there are obviously a lot of health disparities in our area and all across Texas, of course. There are different pockets of health disparities, but specifically with our area in Lufkin, Nacogdoches, and I guess our 12, 15 county region, what are the ones that you all have dealt with routinely, I guess, over the last few years, or that you traditionally see in your position? Because I know you've been doing this a little bit.
Well, I moved to Lufkin at the end of 1992, so I've been working at CHI. It used to be Memorial Hospital, Memorial Health System of East Texas. Now it's part of the CHI Common Spirit Health community for a long time now. And I think one of the things that I love about working with this institution is that it is a nonprofit institution. And so I've never had to turn anybody away for inability to pay, for example. So we have a mission to care for all. And that's the way it should be. The American healthcare system is not set up or designed to treat everyone. And I think, internationally, every system, if you will, rations healthcare somehow. Even if they're a universal system, they may ration by not everybody getting the most advanced technology, for example. But that being said, we do live in a poorer area of Texas, and so socioeconomically, lack of income, lack of insurance, lack of resources for payment is a huge thing. And sometimes it can be up to 15 to 20% of my patients don't have insurance. And that's tough. Plus, in a 12-county region, I see patients every day who are driving 50 miles or more to come back and forth for treatment every day. So transportation, it can be a big issue. So lack of insurance, lack of transportation, or they just can't afford the copays. Boy, January and February get tough when even people who have insurance but have zero savings suddenly get hit with very large copays for the expensive treatment and imaging studies that are done to care for their cancer.
How have things, and we are going to talk a lot about tobacco coming here in just a little bit with World No Tobacco Day around us, but with post COVID and with everything happening, I know, well, you deal in the oncology front. How is that factor in? Because obviously, I mean, cancer patients with COVID, that's not good. So how is that figured in? And have you seen, even though it's been
Yeah.
only a little bit of time, how have you seen that develop?
Well, in the early months of the pandemic in 2020, April, May, June of last year, nobody was getting screening tests done. You couldn't get into a doctor's office. You couldn't get your colonoscopy, your mammogram, your pap smear, all of those things. So our patient load in the cancer center dropped precipitously for many months. And only here in the last month or two has it really rebounded. And part of that is just, again, delay in diagnosis, patients coming in with later diagnoses. And there have been some studies nationally that have looked at that and supported that finding. So we've seen that locally, but I think things are finally getting back to normal, and people are getting in and getting their screenings done.
Good. And what is the recommendation for screening? Is it only after a doctor referral, or there's some other preventative measures that people could do leading up to before obviously needing the actual treatment?
Well, sure. And I think that very much depends on who you are, male, female, age, for example. So, and screening depends on the cancer that you're looking for too. So there are recommendations. The American Cancer Society does a really good job of putting out recommendations for screening, mammography for breast cancer, colonoscopies or the Cologuard Fit tests for colorectal cancer, pap smears for cervical cancer, and you talked a little bit about smoking and lung cancer. Low dose CT screening for lung cancer for people who have a significant smoking history and who have not quit smoking in the last 15 years can pick up early lung cancers when they are potentially curable at a much higher rate than if they typically present later with symptoms if people aren't screened.
What percentage would you say of the cancer patients have ties to tobacco and the lung cancer in their past, or with the lung cancer current?
Right. So, when we look at our top 5 sites in the cancer center, if you will, it's probably in women anyway, it would be breast cancer. In men, it would be prostate cancer. But lung cancer is probably the number 2 site in both men and women, colorectal cancer as well. And then you trickle down to others like cervical cancer or lymphomas, for example, head and neck cancer. But smoking related cancers are not just lung cancer. We see lung cancer, esophageal cancer, head and neck cancer, bladder cancer, and others that can be smoking related that you wouldn't necessarily think of as related to smoking. But all the chemicals, once they enter your system, can cause cancers other locations.
So you've got to answer a question, please, that I deal with kids all the time, students all the time. They don't like being called kids, but they we don't know each other too well right now, but I have a past with my family. I've had relatives that have died from lung cancer. So that's obviously that fuels a lot of my passion. So with the e-cigarette craze that is going now, and I've seen a lot of data, and I'm sure you're privy to a lot of that too. Are e-cigarettes safer than cigarettes, or are they a viable alternative that can lead to cessation? I want to hear your thoughts, because I genuinely I don't know that. So from the medical side, what do you think about how e-cigarettes figure in? And we all know a lot of the history of just traditional cigarettes, but how do e-cigarettes?
Right. Well, I see the idea of using e-cigarettes as a smoking cessation tool as a straw man in a lot of ways. I can't say I've had no patients who have quit smoking with e-cigarettes, but it's rare. It's not a common way that people use to quit smoking. It's really just another nicotine addiction tool, and the vapor is full of other chemicals. So it's different than tobacco, but it's an addictive product that I just it's not the smoking cessation answer. If that's what you're asking.
Mm-hmm. Another thing I come across, and mainly again, 90% of my work is dealing with young people, but I've heard people outside of the classroom setting say this, even off of my part-time job here at the coalition. Well, I've been smoking 30 or 40 years and my body's too used to it. That's one common theme that's come up. I've been doing.
That's called addiction, but yeah.
Yes, sir. I know this, but from the medical side of this, again, I know this is stating the obvious, but the immediate benefit to quitting smoking as soon as possible is the number one benefit, right? There's no benefit to keep ingesting 4,000 to 7,000 chemicals and 70 carcinogens into your body, correct?
Right. No, there is zero benefit and just continued risk. I mean, isn't that what Russian roulette is all about? That bullet's going to fire eventually. I did see a patient today who actually has quit smoking with Chantix,
Great.
A medication to help with smoking cessation. And he's cured of a cancer that was smoking related, and he needed to quit in order to help lessen his chance of getting another smoking related cancer. But just to hear him talk about how much better food tastes, and his voice quality is better, and how much better he feels. But the flip side of that is this morning, I also heard in some hospice rounds of several patients who are dying of COPD and starved for breath. They can't walk 2 or 3 feet without gasping for air, and yet they still smoke. Mm-hmm. And, when you're young, you don't see what the end result of all that damage is going to be. And it's such a shame that kids get addicted and not knowing how destructive and life-altering that decision is going to be.
So the following question is meant, I'm saying it blankly, point blankly, this is meant to be self-promoting for a nonprofit like we are too, with a great program like Project Quit. And of course, I'm biased and I don't do the classes, Dr. Roberts. They just stick me with the kiddos, as I tell the classrooms. But how important is I'm so proud of it because it's gained so much steam, but having a local program like Project Quit where we're starting to do them in person, but able to do them online. How important of a resource is that to go with the Chantix, to go with the passage? I know there are a lot of different ways. Cold turkey, and there are a lot of different ways we can tackle this elephant.
Well, no one way works for every person, and that's why we need to have a variety of programs and possibilities in our armamentarium for fighting smoking. You got to find what works. And I guess you could compare it to diet and weight loss. Not every diet is going to work for every individual, but you keep working at it. And if you're the type that can quit cold turkey, great. But that's not the majority of people. And having programs for the support and education are really helpful.
Mm-hmm. So I pride myself on my prep, Dr. Roberts, in other professions, but I pulled up a quote, and if you don't mind, extend me a little latitude here, because I referenced this at the very beginning, but I had your article, your op-ed, and I forget why I took it down. So my apologies, not that you need them. But anyway, Dr. Roberts wrote an op-ed with our great Lufkin Daily News, 2 or 3 years ago or so, 2017-ish, maybe 4 years ago. Do you remember?
Well, I write one every month, so I don't
There
know
you
when
go.
this one came out.
Okay, there you go. Well, this one was specifically about tobacco, and here's part of it. And my main crutch of this, again, point blankly saying, is big tobacco kills. They're a legalized government killing operation. That's what I tell the kids to lift their spirits. But in this, you wrote, stores that sell tobacco products today are complicit in the very deception that big tobacco is guilty of. The retail markup, and you cite the Wall Street Journal, is 17%, higher than that on groceries. No wonder grocery and convenience store chains put tobacco products front and center in their stores, or even out in front of their stores. Easy money, dirty money. So as I read that back to you, 2, 3, 4 years, whenever it
Yeah.
was, what do you think about that? And do you have any kind of tag on comments to that? Because that was a weighty statement, and I commend you for being so bold in your writing.
Well, it is bold because, grocery stores, their margins on groceries are very narrow. It's hard for grocery stores to make money. I totally get it from a business standpoint that tobacco products had the margins. That's where stores make money. But I do have, and of course, the whole argument in the United States is all about, especially in the last 4 years, individual freedom, individual rights. We make decisions on our own, what we do to our bodies, and the federal government is not going to regulate anything that we do, which again, I don't agree with all of that either. But to the point of grocery stores and being complicit, yeah, you have to accept that if you're going to sell tobacco products, you are complicit. And when you see the lines out in front of the tobacco barns, it's scary. It's amazing how much product they push through. So you can't have a free ride. If you do it, you gotta accept that you are complicit and that you're making money off of people's poor choices, yes, but off of people's health.
Mm-hmm.
So it is what it is.
Unfortunately, it is what it is. You mentioned that, and I wanted to get to that since you mentioned it, a good segue with the recent ruling from the FDA with menthols. And I'll ask you partly point blankly because we're becoming fast friends. Have you seen more African Americans that related to menthol use, and your thoughts on the recent, well, eventually there's a lot of pack nuance in here, the regulation of when and if by the time we're both retired that they actually stop selling the menthol.
Right. They've needed to do that for a long time. We've known for years and years that that the African American community in particular prefers menthol brands, and I the addictiveness of it, the pleasure, if you will. Why are we allowing cigarette makers, manufacturers to put in additives to make a product even more pleasurable and addictive? Well, it's the same thing with vaping, and why were we allowing bubblegum flavored e-cigarettes, for example, to be more attractive to our youth? We are averse to regulating tobacco and nicotine products in this country, and we shouldn't be. It costs so much to care for patients with heart disease, COPD, cancer, and it's the very population that is less likely to have insurance, for example, that is dying of smoking-related illnesses. And here we are, all of us, our tax dollars are eventually, ultimately, paying for this care, but yet we're not willing to regulate tobacco products. It doesn't make sense.
Mhm. And hopefully, just hope on hope that that does eventually come to pass, that it's got a few more years before it becomes
Yeah.
official. But May 31st is World No Tobacco Day. To borrow a cliche, every day is World No Tobacco Day for me. And obviously, in your position, as you're dealing with it on a day-to-day basis, the large effects of tobacco. Any final messages, final words about, and not just with prevention of tobacco use, but what people can do to be healthier, and then in turn, how CHI figures into that. Take that as you will.
Sure. Well, I am all for days like World Tobacco Day, the Great American Smokeout, for example. It's like January 1st being a good day to start a diet, if you will. Sometimes we just need a push. We need a target. We need a reminder to do the things that we want to do. So PR campaigns, educational campaigns, I think are very key. I love that the coalition focuses on tobacco. I love that the American Cancer Society does as well. And the more these organizations work to educate the public and get people to quit smoking, it's just vital. Tobacco cessation is truly the number one intervention that's going to drop heart disease, lung disease, cancer rates in this country.
A perfect quote to end it with, again, citing yourself. You say, "Nothing short of a world without tobacco will do. Perhaps that is a pipe dream, but our kids are worth it." Thank you, sir, for what you do. And that was a great punctuator. Really, really appreciate your time today.
Well, thank you so much for all that you and the coalition does in our community as well. Thanks.
Dr. Sid Roberts from CHI.